Okay, welcome everyone. I would like to welcome all of you on the behalf of Medical Aura community, and we have with us Dr. Shaili Mehta. I'll be briefly introducing her, and then we'll be beginning with the session. There's a kind request that all the questions and doubts they'll be cleared at the end. Okay, so you can put all your doubts on the in the chat box. So we'll have a question answer round in the end or in the group also we can have. So, Dr. Shelley, she completed her MDS in conservative dentistry and endodontics from the prestigious Government Dental College and Hospital, Navi, Mumbai. And she is the youngest fellow of Style Italiano Endodontics from India. That is really amazing. And she has conducted several workshops on microscope, uh, including rubber dam workshops, composite aesthetic workshops, and she's the recipient of the prestigious Pierre Fauchard Award, IACDE Clinical Excellence Award in the year 2024, IES Endo Case Contest 2024, IAACD Pan India Paper Presentation in 2022. So she is the proprietor of the Dental Dream Academy, which is in Navi, Mumbai, and she's amazing. We all know it, and that is the reason we decided to have this Zoom webinar. So I would be requesting Shaili you to begin, so we can take multiple questions in the end.
Yes. So thank you so much. Now, a big thank you to Dr. Anu for this opportunity. Now, without wasting any time, I have a lot of things to say about Dr. Anu, but I'll wait for the till the end. So let me just begin with the session first. You all can see my screen? Okay. Hi. So let's talk a little bit. So Dr. Anu has already given my introduction. I'm Dr. Shaili Mehta. I did my BDS from a college named as MGM, that's in Navi, Mumbai. That's a part of Maharashtra. Then I went for my All India rank 44 in my NEET MDS. Then I joined GDC Mumbai in my dream branch, that was conservative dentistry and endodontics. I was assistant professor for a year, and now I'm a full-time private practitioner in Navi, Mumbai. I'm also the proprietor of Dental Dream Academy, which conducts courses all around India. Okay, so before we begin, so just a disclaimer, this is only for educational purpose and not sponsored by any organization. Okay, so when I say composite restoration, now I'm sure I'm talking to a mixed crowd. So we have people that have actually graduated now or doing post graduation, and then we have people who are actually practicing since 5-10 years. Now, whenever I say composite, what do you feel? What is the first thing that comes to your mind? Is it something like this? So while doing your regular OPDs in college or when you're working in your clinic, you see something like there's an old composite which is fractured, there's micro leakage, there's everything that can go wrong, which is whatever's given in the textbook is wrong with this case. So if you have been practicing for more than 5 years, there might be chances that a composite that you have only done 5 years back is coming to you with this condition. Or a composite like this, which has gap, micro leakage, everything. Or a composite like this, which initially the person who tried to do it maybe tried to give a proper contour to the cusp and everything, but then after polishing and finishing and polishing, this is what the person ended up having, like a flat tooth. Now, so since our BDS days, we have been taught about amalgam, and whenever you say to any senior practitioner, especially any senior endodontist, the first thing they have in mind is amalgam is better, amalgam has self-sealing property. Now, why is that? It's a major reason for that could be also because we have been taught amalgam throughout our BDS. So 4 years you've only concentrated on amalgam, and if you spend 4 years on something, you are bound to be good at it. But when it comes to composite, we directly do it either in internship or some lucky people have done it in their final year. And when we come to clinical practice, तो पता चलता है यार amalgam तो है ही नहीं. So then you are like, "Arey yaar, मैंने इतना सर क्यों फोड़ा? Why did I cry so much before my class 2 exam, where it was actually not important?" So the important question is, so whenever you come out of college, most of the people are frustrated with composite. It's not your fault. You've not been taught composite the right way. If you spend, just imagine, if you spend the next 4 years doing only composites, just imagine the level of confidence you'll have in composites. So then if I'm talking here to a young crowd, please keep it out of your mind that I'm very good at amalgam. You might be amazing at amalgam carving, but it's not important in clinical practice anymore. Amalgam is not there in clinical practice. Now you need to upgrade with time. You need to learn composite. So if your composite is average, try to improve on composites. So with this little bit introduction, let me now take you to a picture what I want you all to imagine. You need a peaceful, mindful dentistry in composite, because you've been doing amalgam for 4 years. You have a muscle memory. You know the every time you show your cavity, I'm sure Dr. Anu will relate to it. She's a staff in one of the colleges, so she'll go. So every day you are taking your amalgam cavity, showing it to your staff, and every time, trust me, this happened to me. Every time they come up with a new version. What is the cavo surface margin? What is the degree? How much convergence? This, that. So you've been trained like that, but when it comes to composite, you have to learn it. So why do you feel that peace and calmness when you're doing amalgam? Is because your brain is trained. So today what we are going to do is a stepwise process to help you understand how to actually go about composites. Okay, now today's specific topic is going to be posterior composites. Now, in the last few years, I'm sure if you have at least done 2 or 3 composites, if you attended this lecture, you understood what the problem is. Now, when I say composite, so what are the challenges in posterior composite? The first one is post-operative sensitivity. Second is marginal discoloration. Third is secondary decay. Now, there is something called as a proper contact and contour, which have been taught to us in amalgam. The same concept. This is the only thing. It is exactly copy paste of amalgam. There is no changes in proper contact and contour. It's the same for amalgam. It's the same for composites. And the last is shade matching, which is a new thing in posterior composites, because most of the people when doing posterior composite, I've heard this in clinics. कोई भी shade दे दो posterior में क्या फर्क पड़ता है? नहीं फर्क पड़ता है, but if you are charging a hefty amount of money from the patient, just give your best shot. Shade matching in composite is for you, not for the patient. You go home satisfied that you have done a good job. That's why shade matching in posteriors is important. And I'm not asking you to have an extensive shade match. You do your enamel, dentine separately. Just have a dentine shade, match it with the tooth, and go ahead with it. Okay. So now when I say post-operative sensitivity, marginal discoloration, secondary decay, it is all related to only one common problem, जिसके ऊपर हमने भर भर के essays लिखे हैं, which is one thing, that is polymerization shrinkage. हमने इसके ऊपर essay क्यों लिखे हैं, LA क्यों लिखे हैं, हर वाइवा में इसके ऊपर आंसर दिया है. What is the common disadvantage of posterior composite or composite rather? एक ही आंसर आता है, polymerization shrinkage. Now let's understand why polymerization shrinkage leads to post-operative sensitivity, marginal discoloration, secondary decay, blah, blah, blah. Okay. Now, when I talk about tips and tricks, so this is going to be specifically for posterior composite. So we are going to talk about right from pre-operative stuff to post-operative stuff. So now, as I said, that we are very used to doing amalgam. Now for composite, I want you all to take screenshots or make notes of exact protocol that we need to follow, because till now, even when I was taught, there was no protocol. This is something that I have made. No one taught me that this is are supposed to be the steps. What has been taught to us? H bond composite khatam. That's not how it works. Okay, so we divide our composite into 3 parts. First would be pre-operative, second would be our intraoperative, and third is going to be post-operative. Okay, now pre-operative procedures. Now when I say pre-operative procedure, these are the things you're supposed to do before you start the patient. Now we all know that composite demands isolation, absolute isolation. Now, when I say isolation, this is what we do when you're doing composite. You put cotton roll, you put all types of suction, and the moment you move to take your etchant, your bonding agent, this is what the patient does. Your entire isolation has gone for a toss. This is something we don't want, and the one common solution for that is rubber dam. I know you've not been taught, most of the colleges are now teaching rubber dam, but if you've not been taught, this is high time you learn rubber dam. In the next 5 to 10 years, this is going to be very, very mandatory. So, first thing is rubber dam. Now, imagine you can have a simple isolation, something like this, like endo isolation, which is a single tooth isolation. You can have multiple teeth isolation, or you can have something like a very complex isolation. Now, in this case, my only concern was not saliva here. It was a maxillary tooth. Saliva, I can still block it with cotton rolls. But my main issue here was going to be gingival clavicular fluid and the blood that comes from the gingiva. Why is that? Because the margins are so deep, the moment I put my composite, either GCF is going to leak or my blood is going to leak and contaminate my restoration. So in such cases, it is literally impossible to go ahead and do a restoration without isolation. Now, second thing that we do is we have been like whenever we were working in colleges, there is one thing that we used to go and there would be a station from where you used to collect your etchant, your bonding agent, and your composite. Now, sometimes you are in hurry, you forgot your etchant, you forgot your bonding agent, you forgot your composite, or the shade that you select is not actually good. Or the worst thing that happens in colleges is that you have one curing light. So you are working here, you have applied your bonding agent, your friend has already taken the curing light, and you're wondering, kya curing light kaha hai? So this is a common thing that happens. So don't do that. Composite dentistry demands your peace and your mindful dentistry. So always make a checklist. Now, whenever you are doing a class 1 composite, you know what are the things you need. And when you're specifically doing a posterior composite, if you're doing a class 1, as a backup, keep your class 2 stuff ready as well. Because if you have done at least more than 5 to 10 patients, you must have realized it does not take time for a class 1 to convert into class 2. If you have not taken an IOPA, you start with a simple class 4, you realize the marginal ridges involved, and your class 1 achanak se becomes class 2. So have your armamentarium ready with you. That will give you much. See, it's very easy to say on my part, but actually when you experience it, you will realize how much difference it makes. Everything is set on your table, so you don't have to run on, your decision making is based on your clinical case and not on wondering yaar bonding agent kahan hai, agent kahan hai. Whenever you start a patient, irrespective of what subject you're doing, even if you're doing endo, composite, your concentration should be in the patient's mouth. You should be one with the tooth. We are in a medical field, anything can change anytime. So, neurosurgeons, your cardiac surgeons, they make decision instantaneously. It's the similar way. If you're doing endo, you're doing your composite, you have to make decisions share side. You can't be having a proper protocol. You pehle se decide karke rakhna hai. And making a checklist will help you with that. So we spoke about 3 things. The mandatory thing is rubber dam. Then there is a checklist. Next thing which we don't do is check occlusion. Now, whenever before starting your case, whenever you know it's a class 1, class 2, whatever, take articulating paper and ask the patient to bite. Take a photo of what points you see on the paper. With this, you know where exactly your tooth is in occlusion. So if you're doing a class 1, class 2, you know where are the chances that you will have a high point. So always check the occlusion pre-hand. Second, in some cases, you might also realize after checking the occlusion that biting forces are very heavy. So you might have facets or something like that. So you can't, in such cases where patient has heavy masticatory forces, don't expect the cusp to be very sharp and have a proper contour. In such cases, your anatomy is going to be relatively flat. Okay, I'm saying relatively, not completely flat. Next thing is also check for proper contact and contour. This will be judged first, would be clinically, you pass a floss through it. Second, you have to take a radiograph to understand first. So when we were in dental school, The only reason we took a radiograph for a class 2 cavity was one, exam mein approve karwana hai ma'am se. Now, when you are in clinical practice, pulpal exposure is not something very scary. You're not going to die. When you come to internship, you realize that. But why to check contour and contact? You're on the radiograph and clinically, you need to see where my margin is going to be. Is it going to be equigingival? Do I have to do my deep margin elevation, or is it at the above level? So today, just today, like before coming for this webinar, I had a case where I took a radiograph. I realized it is above the line. It was above the contact area. So immediately I told the patient this is going to take around half an hour. It's a very simple case. The same case, if I'm not talking about how deep is the cavity, I'm talking how much the radicular dentine is involved. And if the same case, it was not that deep, but it was involving the radicular dentine, I would have supposed to do a deep margin elevation, stuff like that. I would have easily taken around 1.5 hours to 2 hours. So with this, checking the contact and contour on a radiograph, you understand what is going to be your treatment plan. Okay. And the last thing is that having a good curing light. Now, what do I mean by curing light? Now, in theory, we've all read about this, that the minimum intensity of curing light should be around 400. Okay. Now, in market, no company will give you a curing light that has a minimum of 400. Most of, if you've spoken to any salesperson or anyone from this curing light companies, whatever they say, 12,000, 1,200, 1,000, why is that? Why are they claiming that? Because once you buy a light that is around or above 1,000, it was gradually going to decrease. So the curing light, irrespective of the company that I buy today, it might be the most expensive company. But if I buy a curing light today, after 2 years, the intensity is going to decrease. It does not gradually decrease in good companies, but if you're buying a very cheap company, after a certain point of time, only blue light is coming. It is not curing your composite. So if you are following every protocol that I've told in this session and still your composite is having sensitivity or your composite is coming out, especially in one chunk, it is because your curing light is not proper. So invest in a good curing light. These are, again, it is not a sponsored video. These are some of the standard curing lights we have. We have one Blue Phase by Ivoclar. We have Elipar, that's by 3M. All these lights are gold standard, so they have a uniform intensity. These are expensive light. It does not mean that the intensity in this cases does not decrease. It does decrease, but the amount at which it decreases is very less. So make sure you invest in a good curing light. Now we move on to the intraoperative, the interesting part of the lecture. Now, first step is caries excavation. Now, every time we see a cavity like this, we isolate it, and by intuition, or I don't know why, but we take our burr and drill straight in the center. This is how we do it. But remember one thing, we are doing composites. Composite bonds well to the enamel and bonds less to dentine. So why not remove caries from enamel, have a good peripheral margin, and then move on to dentine? That's a simple logical solution. Why are we directly going into dentine and making dentine caries free? Make your enamel caries free. So what we are going to do is something like this. We start from the periphery and then go towards the center. This is basically called as a centripetal form of caries excavation. Then next step is caries detection dye. Now why do we use this? There's only one reason, because human eye cannot detect caries completely. So we need something like, this is by ultra-red. So we need something like this that will help us to distinguish. So once you applied your caries detection dye, you will see 3 zones. One would be your superficial enamel, second would be your affected dentine, and third would be your infected dentine. Now, the next thing is to what all these 3 zones mean. The first is the central stop zone. The second is caries removal endpoint. And the last is the peripheral seal zone, which is the most important for our composite bonding. Now, what are the steps in composite? Just give me a minute. Sorry. So what are the steps in composite? We have our cavity, we apply etchant, and then we rinse it. We apply our bonding agent. Okay. Now today I'm going to talk about something that we've all read, all written 3-4 liner definition answered in our Viva, but now today let's understand what it exactly means. Now, when I say hybrid layer, what does it exactly mean? Everyone has heard of hybrid layer, I'm sure. Now, what does it exactly mean? So, hybrid layer basically is that we etch the enamel, we etch the dentine, there are micropores created. We take our bonding agent, we scrub it over our etched enamel and dentine. The bonding agent goes and seeps into these pores. The layer that forms between the dentine bonding agent and the pores that is there, it is called as a hybrid layer. So right now, for illustration purpose, the red line that you can see is basically the hybrid layer. That is a layer of your dentine bonding agent with your tooth. Then we cure it, we apply our layer of composite. This is how we do it in college, right? We apply a very thick layer of composite. Now, what exactly happened? Now, earlier they used to say that the composite shrinks towards the source of light. I'm sure a lot of you must have written it in MCQs and must have read it. But now, what they say, composite always shrinks away, that it shrinks towards the center of its mass. Now, when this happens, there is the tremendous amount of shrinkage forces on composite, and this shrinkage forces are in fact applied to your hybrid layer as well. So the composite itself shrinks, but it also breaks down the hybrid layer and makes sure the hybrid layer also shrinks with it. Now by rule, we apply our next layer of composite. We again cure it, and now the force is going to be even more. So again, there is when you cure it, there is again breakage in the hybrid layer. Now by rule, it is a general rule that body does not like any empty cavities. If you have a cyst, it is filled with fluids. If you have a simple pimple also, it's filled with something. The body does not like any cavities. So body is going to try and fill this up with something. Now the only fluid we have in this area is going to be your dentinal fluid. And by definition of sensitivity, we know that rapid movement of dentinal fluid leads to sensitivity. And this is the exact time when you do your composite restoration after 1-2 days, when you get a call from your patient that, doc, I'm having sensitivity. This is the reason why your dentinal fluid is moving inside and causing all amount of sensitivity. Now again, this fluid is causing pain, it's causing discomfort. Again, body does not like discomfort or pain, and it is causing some pressure. So it is going to try to remove this pressure from this area, and the only way that can happen is through this month. Now here the pressure is released, but now do you realize there is exchange of microorganisms with the dentinal fluid? So this is the time. So basically, when your patient calls you that, doc, I'm having sensitivity, and we tell the patient that, it's going to be fine. Just wait for 15-20 days. This is what happened in 15-20 days. The pain goes. Absolutely, the patient is not going to feel any pain. But now, because of the bacterial ingestion in the cavity, the patient is going to have secondary decay. And similar case, this happened. This is one of my students. So this kid came to me with the chief complaint of, he felt that there is problem with the distal cavity that's there. He was saying that he got his mesial cavity filled. He had pain for 15-20 days. He was absolutely fine, and he's been fine till now. But now he's having sensitivity and pain. I isolated the tooth and found it to be a little suspicious. So went ahead and excavated it. Now you would realize the mesial cavity is a bigger culprit than the distal cavity. And this happened because of secondary decay. What was there in distal was just a primary decay because of caries. But here it was secondary decay, much more worse than it. So why does this happen? It's because of a simple concept called as hierarchy of bondability, which is a problem for us. Now we all know that enamel is better than dentine, and as we go deeper in dentine, the bond strength decreases. Now, We all know, we've been written answers, we know, we've been taught and understood the difference between enamel and dentine bonding. Let's now have a practical live example of, every day-to-day stuff that you use. Consider your enamel to be your Fevikwik and your dentine to be Fevicol. If you want to stick two things immediately, you use Fevikwik. Fevikwik, your enamel does not need time. It immediately sticks. But when we talk about dentine, it is something that actually requires time. So if you've seen your carpenter work at your home, so you must have seen they apply your Fevicol on the plywood. They wait for some time and then they stick it to the wood. Realize that? So it needs some time. Dentine needs time for maturation. Now, how do we probe? So the problem was hierarchy of bondability. Now, how to solve this problem? So we have two things. One is immediate dentine sealing and second is decoupling with time. Now, whenever you're preparing a cavity, you are creating some amount of distress on your pulp or your dentinal tubules, and this leads to an outward movement of your fluid. If this fluid is not stopped at this level, it is going to be there, and this fluid is at microscopic level. So you will not be able to realize that you have actually entrapped something. So once you have your immediate dentine sealing, what is this concept? Once you have your outward flow of your dentinal fluid, you immediately seal it. Now, how do we do it? We apply a layer of bonding agent. Now, this bonding agent recommended by Pascal Magne was OptiBond FL, that is by Kerr. Now, why this specific bonding agent? Because it was believed that this bonding agent has 70% filler content. So, because it has 70% filler content, it is very thick. But unfortunately, this bonding agent is not available in India. So the alternate again suggested by him is to apply a universal bonding agent. Now, what does this universal bonding agent mean? A bonding agent that has etchant and primer within itself. It's just a one bottle system. So it has a etchant, but it's a very primary or a very weak acid that's there in the composition. So we use a very, very thin layer of our bonding agent, universal bonding agent. And since the filler content is less, we use again a very thin layer of flowable composite. So now most of the people get confused with immediate dentine sealing. Immediate dentine sealing is without any form of etching. I've prepared my cavity. I apply a very thin layer of bonding agent. I scrub it well. I cure it. Then I take a very thin layer of flowable composite, put it on top of my dentine bonding agent, that is my universal bonding agent, cure it, and that's it. There is no etching involved till this step. So this is what immediate dentine sealing means. Now, once this is done, we have to do something called as decoupling with time. Now, what does this mean? I have done my etching, I've applied my bonding agent, I have cured it. Then I have applied a layer of flowable composite, I again cure it. Now wait for at least 5 minutes to 30 minutes. This is what the literature recommends. Even if you wait for 2 minutes, the bond strength is increased by around, let's say, 30%. What literature recommends is to wait exactly for 5 minutes. And this 5 minutes waiting case not going to be possible unless you have a rubber dam. So once you have your rubber dam in place, you can wait for 5 minutes. So waiting does not exactly mean waiting. How do I utilize that? I take photos. I select my matrix in that time. So these are the things you can do while waiting. But nothing should be put in the cavity before 5 minutes. So till now, we have not done any amount of etching. Okay. So this is our dentine maturation. If in case the cavity is very deep or it is wide, then what you can do is something called as fiber reinforced composite. Now, what does this mean? You have done with your immediate dentine sealing. There are fibers that are easily available. So you put these fibers You dip a little bit of fiber in your bonding agent. You cut it. You place it in the cavity and cure it. Why fibers? It acts, again, giving you a real life example. It acts similar to the way your iron rod work in concrete. Whenever you're building there's a building being constructed, so you must have seen that iron rod, and iron rods may they put concrete. Concrete itself is very strong, but with the help of iron, it is just reinforced. So composite is strong, but with the help of fiber, it is just reinforced. Okay, so we have this option of putting rebond fibers. So we apply dentine bonding agent, we apply flowable composite, we let it mature, then we take our fibers, we put it inside, and now the next layer is again going to be a flowable composite, because we don't want there to be any voids when you place fibers. So these flowable composite is going to go, and again, flowable composite is very weak because the filler content is less. Irrespective of what the company is claiming, it is always going to be weaker than your packable composite. So use it in minimum quantities. The only reason we are using here is to avoid any void formation. Okay, so again, we cure it, and now moving to post-operative protocol. Now, let's talk something that was at least not taught to me in my BDS day. That was oxygen inhibition layer. Now, how do you think one layer of amalgam bonds to another layer? We've all read in theory it's through your excess mercury. So you have one layer of amalgam, it bonds to the second layer of amalgam with the help of excess mercury. Now, ever wondered how does one layer of amalgam bond, one layer of composite bond to the other layer of composite? That is simply with the help of one simple thing, that is your free radicals. So you have your first layer of composite, it has free radicals on its surface, and these free radicals help to bond with the second layer. And similarly, in the last layer, this is what happens. But when we come to the topmost layer, now I don't want my composite to bond to anything, because now it is going to attract dust particle. It's gonna attract stains from turmeric, chili, everything. And the worst thing, it is going to attract all the stains, your tea, coffee, everything. So this is the reason that most of y'all, if you have done a composite, a good composite, that's looking beautiful on the chair, and you call the patient after 2-3 days, you see a full yellow amalgam, full yellow composite. I've said so much about amalgam. I keep saying I think I'm getting confused between amalgam and composite now. So excuse me. So this is what you see. You know, you've done a good composite that looks beautiful on the chair, but after 2 days it is completely yellow. This is the reason. Now, how to prevent that? The only logical solution is to apply something that is water soluble and which is going to inactivate the free radical. So a simple solution of KY jelly or glycerine that is applied on the surface and cured, which will help you to overcome your oxygen inhibition layer. The next step is to cure it. Okay, now when since this is about posterior composite, we also need to talk about matrix band and retainer. Now every time I post a case about class 2 composite, this is the first thing people ask me: what matrix band and retainer did you use? So or what is recommended for all cases? I'm sure some of you all might be having this question in your mind, which is that one system I'm supposed to buy. Simple answer: there are so many matrix band and retainer available in the market, and these are the most famous ones. There would be at least thousands of matrix band and retainer available. So what is my answer? Which is that one system you need to buy? There is absolutely no one system. You have to have multiple systems. If you still want to short down, you know, have like a proper, if you're a beginner and you want to have your minimum inventory, you can have two types of retainers. One, obviously every one of us have, but I've seen this, that when PGs, and especially once you pass out, you throw these bands, you throw Toffelmeyer, thinking that it's only used for amalgam. No, it can be used for composite as well. Of course, you have a circumferential ring by Garrison that works amazing. But if you don't have that, your Toffelmeyer retainer is going to be helpful in such cases. Second, whenever if you want to have a ring system for your matrix band and retainer, always and always have a ring system if which has a wedge in the end. Here in the PPT, can you see the end of the blue area? There is a small V triangle. So this area is going to be for my wedge. Never buy a ring system that does not have space for your wedge. In that case, either your matrix band is going to either your retainer is going to fit or your wedge is going to fit. And when you use such type of retainers, your wedge is also going to be there and your retainer is also going to be there. So what system I use is the bottom orange and the green rings. I use dual force. I have used Palodent. Both are good enough. I have used TDV. The only problem here is it does not give space for your wedge. So and I don't feel that any amount of restoration should be done without wedge. So I have this, but I've never used it. And of course, our very old Trophomer is of course there. Now, how do we place the retainer and the matrix band? Here, everyone says that it's very important to have magnification in endo, but why it is important in restorative dentistry as well, I'll tell you. All my courses are under microscope, all my composite courses. It's because of this one reason. Your matrix band and retainer are supposed to be having a assembly like this. If you could, of course you can't, but if you could look at a restoration from side, this is how it's supposed to look. Your matrix band extremely tightly placed to your tooth and your wedge is supporting it, retracting the gingiva. All the functions that you've read in your textbook, your wedge and matrix band are doing it. If you have something like this, where your matrix band is very loose, your wedge is somewhere else. Now, this specifically happens when you are new to rubber dam isolation. The blue thing that I have marked, if you are looking it even under your loops, you will be able to see your rubber dam sheet coming out of your matrix band. So basically, the yellow is the matrix band, blue is your rubber dam sheet, and wedge is the red circle that you can see, which is placed somewhere else. If you have something like this, you are definitely going to have post-operative sensitivity, micro leakage, everything, because this rubber dam sheet is basically going to allow all the composite to go in and allow the saliva to come up. So never have an assembly like this where you can clearly, it has to be that your matrix band is exactly adapted to your gingival floor. This is true for amalgam, this is true for composite as well. There are no separate rules for composite. It is the same. The adaptation is going to be same. Or you could have something like this, where your wedge and your retainer are, your matrix band are so tight that you have a loose contact on the top. So never have these things in mind. That's why I said never, one assembly is never enough. Something that if your previous kit worked out with Palodent, it might not work out this time. This time you might need a BioClear, which has a wider contour. So every time, that's why in the beginning I said evaluate the contours and contacts, and according to that, select your retainer and matrix. Now, I hope in this almost 1 hour, we have been a little stress-free about dentistry. What we spoke about was pre-operative, intraoperative, and post-operative things. So we have rubber dam excavation, rubber dam checklist, chalking occlusion, contact contour, selection of curing light. Intraoperative, we have centripetal caries excavation, immediate dentine sealing, decoupling with time, matrix and retainer selection. Post-operative, we have oxygen inhibition layer, and of course finishing and polishing. Now we've covered everything, only finishing and polishing is left, which I will be explaining in the clinical cases. Because I am a hardcore clinician, so I'm not an academician, so I like to teach more in the clinical aspect. So this case we've already discussed, caries excavation, dye application. So here, this is the step. So if you might ask me that there is this brown spot, now which is called as a caries excavation endpoint. This is a philosophy by the David Alman. So what they say is if the cavity is 5 below the occlusion level, you can leave the caries as it is. This is not a soft caries. This is actually a very hard caries. So I've done that. You can see the green spots here. That is for caries excavation dye. Okay, so we have excavated everything possible. Then you can see a slight shiny appearance on the cavity. That's because I've applied my bonding agent, and now I've cured it, and now apply flowable composite. So this is the time I told you, right? You have to wait and waste time. I do photography in this time. So I've applied my bonding agent. This is my flowable. Now just imagine how thin the flowable composite here is. Now this is a deep cavity, so I had to do something called as fiber wallpapering. You can see I've placed fibers on both the sides. Then we go ahead and place our next layer of flowable composite. Then now is the time I have used my etchant for the first time, which is for selective etching. Enamel has to be etched. I am sure that this lecture has been taken so many times across all the platforms that I'm sure there'll be a question that why not enamel, why not etch the entire tooth? The only reason is dentine is very sensitive. If you use etchant on the floor where in a very deep dentinal caries, you are going to induce some amount of osmosis. Your dentinal fluid is going to move out, and outward movement causes sensitivity. Okay, that is the first reason. The second question, most common, is in which cases we use selective etch, in which cases we use complete etch. So this we'll discuss in the end. I have a case. And the third thing people ask me is etchant required? Absolutely yes. There is no doubt is whether etchant required or not. Etchant is required provided your etchant is not causing any damage. So if you have a cavity which is only in enamel and you're asking me, can I use only universal bonding agent and go ahead? No, you can't. You have to use etchant. Even if you have a very deep cavity, you've used your universal etchant, you've followed the steps till now, still you have to use your 37% phosphoric acid for your etching. Okay, then we start with our build-up and a pretty decent job with the composite. This is the step where we usually stop. Now I want you, if I remove the rubber dam sheet and ask the patient to come after 2 days, I'll definitely see a yellow spot. Entire yellow discolored, irrespective of whether I apply glycerine or no, I will see yellow. Why? Because it is extremely rough. Glycerine has a limit. Smooth surfaces, it will not allow stains to get stuck. But look at the margin. It is completely rough here. It's rugged. So I have to do my finishing and polishing. Now, a common question, posterior composite does not need polishing and finishing. But just imagine you are using composite from the same syringe. You don't get separate syringes for anterior composite, posterior composite. You get syringes based on shade, your enamel, dentine, translucent, etc. So how does composite know कि उसको आगे के दांत में प्लेस किया है कि पीछे के दांत में? It's going to be the same. I'm not asking you to polish your composite for 45 minutes as you do in anterior. Actually, even that's not recommended. But at least have this decent, smooth, glistening appearance of your composite. So what is my go-to sequence for finishing and polishing? Again, there are thousands of systems available. Again, a common question people ask, what system to use? There are two systems, okay? Irrespective of the company, you have to use your disc first and then your spirals, always. So this photo that you can see is from 3M. It's called as Soflex. If you don't want this, there is something called a Shofu, which is super buff. Even those are discs. There are usually 4. So follow the sequence, whatever is so coarse, medium, fine, and super fine. Okay. Once you're done with your coarse disc and everything, then you have your polisher or your spirals. So you always have a pre-polisher and you have a polisher. Then this is additional. I don't use this anymore. This is Super Buff by Shofu. It is similar to what you used to use for your denture, the buff you used to use. This is similar to that. This you are supposed to use with water for a glistening appearance. This is how my final composite looks like. It's a decent composite, not a great composite, but this is what we need. We want, the patient does not want excessive anatomy or excessive secondary grooves and all. He just wants the tooth to be functional. You have to give a good polish because it's for yourself. and for you to learn composite, and you want the composite ultimately to last. If you have very deep grooves, very deep fissures, the food is going to get stuck. You'll eventually have a decay there. We don't want that. We want our area to be self-cleansing. Okay, so this is the restoration. Again, I did that after, see, there are no high points. Now, this is what happens. Composite restoration before and after occlusal reduction. A very relatable meme, I guess. Something that happened in this case as well. So here I saw that this is again my student. So here I saw that this kid came with a broken amalgam. Now, amalgam breaking is not my issue here. Look at the mesial cavity here. It's not a cavity, it's a facet. I asked him whether amalgam was placed, and looking at the form, I realized there was nothing placed there. It's a facet. This boy would be hardly 22, 23-year-old, but still he's having facet. So I realized it's going to, this patient has a very heavy occlusal load. So I can't give my exact anatomy contours in this case. I have to be as minimum in giving contours as possible. Just make sure it is anatomically perfect. So that's the reason the amalgam failed. It's not because of the cavity design, it's because it was not taken into consideration the occlusal forces. So we went ahead with our rubber dam isolation, and this is a simple anatomy that I gave. Nothing complex, a very simple anatomy that I gave him. This is again a class 2. This is the case we saw. Initially, I used to do a lot of staining and all. Later, as I matured, I realized it's not important to do all the staining. It's just for fun and just for Instagram, but we are not doing dentistry for Instagram. We are doing it for our patients. I used to do, back in college, I used to do all this. So again, class 2. Now, one rule in class 2, whenever you have class 2 as a life phenomena, may try to make dentistry as simple as possible. And how do we do that in class 2? By converting class 2s into class 1. So convert your class 2 into your class 1 restoration and then go ahead. This will make your life much more simpler. And always take a radiograph. Now in colleges, we used to always take a radiograph before getting our class 2s approved. That was just for approval. But how many of you all have actually taken a IOP after you have done your class 2? I'm not talking about composite, even after amalgam. If you've not, tomorrow onwards, if you're doing your first, if you're going and doing your class 2, irrespective of what material you're using, just take IOP. There are high chances you'll be highly disappointed with the work you've done. Till date, I have butterflies in my stomach. After I'm done, I remove the rubber dam and everything, and I take IOP. I still have butterflies. Yaar, void to nahi hoga. How would be the contact? What you see with your naked eye or your microscope is just the occlusal view. Your proximal view is in class 2s is only depicted by a radiograph. Preferably a bite wing. If you can't get a bite wing, get a normal radiograph, but make sure you get a radiograph. Again, a class 2, this was done for a dentist herself. Yeah, this is the case where, I can explain where we need to go and do selective etching, and where we actually need to go and do our total etch. So here we have 4 teeth, out of which only 6, my first molar had a deep cavity. So I went ahead with my universal composite, universal bonding agent, flowable composite, curing it, waiting for 5 minutes, then doing my universal etching. And on the rest of the teeth where the cavity was very shallow, I went ahead and applied only etching. I did that. Now I don't do my stainings anymore, but if you all want to, this is the stain that I've used. It's by Tokoyama. Next, again, a case. So we've answered all the questions apart from one, which is shade matching. Now, when I say shade matching in posterior composite, very simple, use the Bulton technique. There's nothing wrong. In case of anterior, there are 10,000 different ways of shade matching. For that, you need to come for my course. But for posterior, just use the Bulton technique. Use dentine shade always. Now, why use dentine or body shade? Again, you need to come for my course. So I would like to say that these tips and tricks will help you provided that you have given enough time. The cases that you all saw are a work of at least 5 to 7 years of clinical practice. All cases were done by me, of course, but it was not like none of these were my first initial PG cases. All have been done after a lot of practice. So tomorrow, even if you follow everything and you don't see a very good outcome, or you see a demarcation line, don't be scared. It is common, it is natural. Just give yourself some time and you will improve. Okay, so any questions? If you have any other queries apart from the topic of posterior composite, please contact me, or this is my Instagram handle, or you can write out to me, you can send me a mail. So I hope this session was helpful. And so most of you all know me as an endodontist, blah blah blah, but today I have this opportunity to actually thank Dr. Anu. You know, there were times in my PG, she knows I broke down in my PG. There were horrible times in my PG where I was scared. I didn't know what to do. I always felt that I'm not doing enough. And she was the one who cheered me up through all the difficult days. So I have a lot of respect for Dr. Anu. And we never knew each other. It was only through, I think, Facebook we contacted, and she helped me out like my elder sister. She was not supposed to. I mean, I she has done so much for me that not even my seniors that were there in my college have done. So she's one person I look up to as a human being. Forget about dentists. I look up to her as a perfect human being. So thank you so much, Dr. Anu, for everything that you've done for me, ma'am.
You had been amazing since your post graduation. I still remember. You were amazing since till that time.
Thank you so much, ma'am.
You were outstanding. I do remember. You used to share your cases. You used to tell your cases. They were amazing. We have a lot of questions. We can take few questions right now, and
Sure,
rest
sure,
we can
sure.
discuss on WhatsApp also.
Done.
Okay. So, this question from Dr. Tom, that you are placing a posterior composite in a patient with bruxism. The occlusal forces are clearly evident. What modification in the material choice or the technique you would consider for the case?
Okay. So material wise, in most of the cases that I'm using, I'm not a very big fan of using microfill composites for anterior because it gives aesthetic. Blah blah. I don't believe that. In that case, I've used nano hybrid composite that was by 3M. So I've used that composite. That is preferably the most strongest composite that was available. And what other options did I have in that case? It was a minimal. I could not give a crown. I could not do anything else for that tooth. And that particular tooth had a problem. It was not like it was a generalized adhesion. You could see in the 7, it was absolutely fine. So I can't give him a night guard also. It's just the problem is that tooth. And because he was too young, I did not want to damage the opposite tooth with an enameloplasty, or remove the plunging cusp or something like that. If the composite fractures, I'll redo the composite. But I don't want. I never touch a healthy enamel. That I think is criminal to touch a healthy enamel in a young kid who's 22.
Yeah. And we have uh, after immediate dentin sealing, we will etch enamel. So once etch was washed off, should we again apply the bonding agent on the dentin?
Yes. I forgot about that. So your etching bonding are always going to be complementary to each other. So first would be your immediate dentin sealing, then you apply your selective etch, then apply your bonding agent, cure it, and then your composite.
And what are the instruments that you are using for your composite placement?
So I have two sets of instrument. One is by LMR, that because I'm a fellow of style Italiano, I prefer those instruments. But apart from that, there are great instruments by, I think the company is Ident, is Indus Bello. They, if you all want, I'll share the contact details and the instrument. They are great instrument. They're as good as LMR. LMR is a little expensive.
Yeah. Uh, what are the alternatives for fiber reinforced apart from rebond?
So you have fiber reinforced composite as well. You get those capsules that is by GC. So the fibers are incorporated in the composite itself. So that's one alternative. Apart from that, there is no alternative. You can do it without fibers. So there have been studies that say that fiber is not actually creating anything good or anything, but it's, I don't know. I follow what Dr. Alman has done so throughout these years. So I prefer in deep cavity, I prefer to use fiber, not in simple cases, not in simple class twos. So apart from that one case, you saw all the 7, 8 cases, I never used fibers.
Yeah. With the control zone that you said, does it mean we are leaving the caries in that area, the control zone?
So here there is a controversy. So according to Elman, they say that even if it's soft caries, you are supposed to leave it. That is something I don't believe in, because if it's soft, it's filled with bacteria and stuff like that. So if I feel it is affected dentine, then I leave it behind. If it's infected, I'll remove it. That's my ideology, irrespective of whether I'm having a pulp exposure or not.
And we have Dr. James. He wants to know how you are managing over contoured restoration.
I'll have to redo it. You're talking about class 2, right?
Yeah. In a
Yeah, so I'll have to redo it. There's no other way in class 2. So I have seen this time where your restoration, he's talking about over contour, but
yeah.
sometimes your restoration is defect. There's a little space between two of your class 2s. So I've seen people place matrix band without etching, bonding, anything. They just apply flowable and just hope that it stays. So that does not work. If you have anything wrong in class 2, you have taken IOPA, you see that it's wrong, massively wrong, you have to repeat. If it's a void which is there in between somewhere, you can still not, repeat the entire restoration. You can just be hopeful. If it's in between somewhere, it's a small void. But if you see some problem with the contact and contour, you have to repeat your restoration. There's no other alternative.
Okay, we have Dr. Shruti. She is asking, after doing a posterior class to composite restoration, it is noticed post removal of the wedge and the matrix band, the contact is not very tight. No space is visible clinically, but dental floss is passing easily. Is there any way to rectify this, or I think you will say you have to redo it. Uh,
Yeah, so basically how you do it, suppose I have two adjacent cavities. As per rule, you restore the smaller one first. So initially I apply two matrix band, I restore my smaller cavity first, then I remove this matrix band. Don't let this matrix band be there. Okay, and after that, once I'm doing the larger cavity, suppose I'm doing 5 and 6. So 5 is done now, I'm moving on to 6. Now, whenever I'm curing, I said that you have to convert your class 2 into class 1. So when I'm building my proximal wall, I'll make sure with my instrument, I'll pull my matrix band towards 5. So because of that, in case if there is any discrepancy, any problem, so I'm overcompensating it by just pulling my instrument. This instrument, if your matrix band adaptation, your wedge adaptation is proper, is not going to give you your over contour restoration. So after doing this, once you cure it, the final indication is after you are done with everything, you are not supposed to be you should not be easily able to remove your matrix band. You should have some resistance while removing it. You should apply your force. You should use two of your tweezers. Nowadays with this dual force, you get special tweezers because it's difficult to remove with a normal tweezer. So if your matrix band is coming out easily, that means your contact was defective. That means your matrix band adaptation itself was a problem.
proper. Which buff you use for polishing?
So in this, I used to earlier use, it's by Shofu. It's called Super Buff.
While you are
Sorry, Super Buff is the company of the buff, and now I realize by finishing and polishing, the name of the kit is Super Snap, not Super Buff. Super Buff is only the buff. Super Snap is the disc that you can use for polishing.
okay. So while you are converting class 2 into class 1 by building the proximal wall, you are doing it with packable or a flowable composite.
So initially, the first layer, once I see that my matrix band is closely adapted to the wall, to my matrix band is adapted to my gingival seat. Very thin layer of flowable composite I apply only on the gingival seat. This is just to seal my margins. Because irrespective of what company, whatever's happening in this world, I still believe flowable composite is weak. So I try to use it if I directly go ahead and place my packable composite, there are chances that I might have a void. You can also use a compule, but I don't know. I've been using flowable in that very thin area, but I'm very comfortable using that flowable, then I might use a compute.
We have Dr. Dipti. She wants to know if the patient is experiencing post-op sensitivity, then how do you go about it?
Repeat. They take a IOPA first. Just see if nothing is wrong, and if everything is fine, your cavity is shallow. I mean, it's not into the pulp or anything. Then you have to repeat it. And while repeating, it's very difficult because if you've done a shade matching, now it's going to be even more difficult to recognize where your composite end and where your dentine starts. So repeating this restoration is again a very big challenge.
When you use total edge technique, where selective edge or partial edge, I think the question is
Was the
not clear.
answer? Yeah.
The question is not clear. If near to exposure during excavate, the caries precautions to be taken.
Let it get exposed. That's my only way, because I'm not a very big fan of leaving any bacteria behind. Let it be exposed. If you want to be conservative, do partial pulpotomy or something like that if you are comfortable. But I'm not someone who would see that there's only 0.5 mm of dentine left. I can literally see the blood behind my dentine, like below my dentine, and I'll still do a composite. I'm not that. I would straight away go and let it get exposed. In colleges now, anyone below, like who's in final year, they think it's a crime to expose pulp. It's not. If the bacteria has gone deep, you have to do it. It's okay.
Yeah. The participants, they want you to put the details in the WhatsApp group for the
Done. I'll do that. I'll do that.
And there's last question for the interiors mylar strip placement trick, if so that it does not stick while curing to the composite.
Don't use mylar. That's the only solution I give. People use bonding agent and stuff like that. You're just damaging the properties of composite by using excessive bonding agent. Earlier, used to, even in my college, it was taught to me that you use bonding agent on top of your composite. It looks very beautiful. Blah blah blah. You are actually inducing your oxygen inhibition. You are actually inducing your free radicals in that area, and there are more chances that you'll have a yellow restoration next day. So the same thing happens in anterior. Do not use bonding agent unnecessarily when it is not required.
So we have questions regarding apexogenesis and pulp capping, but it's better we'll keep another webinar for these
Yeah,
pulp
definitely.
capping. But
Yes.
what system you are using for the diastema and anterior?
Anterior diastema depends on the case. I'm more comfortable using the conventional method of using the posterior saddle matrix in a vertical fashion like this for diastema closure.
Okay.
That is what I use. BioClear is also good, but I'm more comfortable with this system. I've been using that. It's more manual. You have a more, it has my touch. BioClear, you place for flowable composites, done. So I miss that when I use BioClear. And again, there's a lot of finishing and polishing involved when you use BioClear and stuff like that. When you're doing manually, you can actually, while building up, you can actually contour your matrix band, your restorations through the matrix band.
Okay. Thank you so much for today's session. It was really, really amazing.
Thank you
I think
so
I'm
much,
listening it for
Anuma.
the second time, but
Second time, yeah.
it was still amazing.
Thank you so much.
Thank you to everyone. And any doubts, you can contact directly to Dr. Shaili, or you can put in the group also. Thank you.
Thank you. Bye bye, guys. Good
Bye.
night.
Good night. Take care.